Welcome to this clinical review on the differential diagnosis for a child waking with fear. This guide is designed for postgraduate psychiatry residents to help distinguish between 4 key nocturnal episodes: nightmare disorder, sleep terror, frontal lobe seizures, and REM sleep behavior disorder. Let us break down the clinical features of each to aid in accurate diagnosis and management. First, let us look at nightmare disorder. This occurs during REM sleep, typically in the second half of the night when REM sleep is dominant. The peak age of onset is between 3 and 6 years old. Episodes are infrequent and last only a few minutes. Motor behavior is quiet, as the child rarely moves due to normal REM atonia. Autonomic arousal is mild, perhaps presenting with some sweating and tachycardia. Upon waking, the child is rapidly oriented, alert, and easily comforted. They will usually have vivid, story-like dream recall. Management includes imagery rehearsal therapy and processing. Next is sleep terror, also known as night terrors. Unlike nightmares, these occur during non-REM sleep, specifically stages N3 or slow-wave sleep, and usually happen in the first third of the night when deep sleep is dominant. The peak age is slightly older, ranging from 4 to 12 years. Episodes are infrequent, but can last anywhere from several minutes to half an hour. Motor behavior is dramatic, featuring an abrupt sit-up, thrashing, and a panicky scream. Autonomic arousal is massive, often presenting with mydriasis and extreme tachycardia. The waking state is characterized by disorientation and confusion, making the child very difficult to console. Notably, there is complete amnesia for the episode. Management focuses on reassurance and safety, though benzodiazepines may be used if the episodes are severe. The third condition to consider is frontal lobe seizures, specifically autosomal dominant nocturnal frontal lobe epilepsy. These can happen in any sleep stage, often during non-REM or sleep transitions, and can occur at any time of the night or even during daytime naps. The peak age is variable, but it often has a childhood onset. These episodes have a high frequency, frequently occurring in clusters, but are very brief, usually lasting less than 1 minute. Motor behavior is highly stereotyped and hypermotor, such as repetitive bicycling motions. Autonomic arousal is variable. Upon waking, there is a brief period of postictal confusion, and the patient has complete amnesia for the episode. Management typically involves anticonvulsants like carbamazepine or oxcarbazepine. Finally, we have REM sleep behavior disorder. This occurs during REM sleep due to a loss of normal atonia and usually happens in the latter part of the night. While it is an important part of the differential diagnosis, it is crucial to note that the peak demographic is males over 50 years old, making it rare in children, but it presents as variable, chronic, and progressive. Motor behavior involves active dream enactment, such as flailing, punching, or kicking. Autonomic arousal is variable, but the physical actions can become violent. Following an episode, the patient is immediately awake and oriented, and their dream recall will perfectly match their physical behavior. Management prioritizes bedroom safety, alongside pharmacological interventions like clonazepam or melatonin at doses of 3 to 12 milligrams. By carefully evaluating the sleep stage, timing, motor behavior, autonomic arousal, and the patient's recall, clinicians can accurately differentiate these nocturnal events and provide the most appropriate and effective management for their patients.